Good morning, everyone.
Good morning, ma'am.
Yes. So, good morning and welcome to all our viewers. Some are already joining, and this is another episode of Oral Pathology Tuesdays. It's marvelous to have you all here. Besides Dr. Vijayalakshmi Kotrashetti, who is a speaker today, we also have Dr. Bhavna and Dr. Priya, who are helping as usual. It definitely takes a village. So they are helping, and I'm grateful for that. We also have a number of people joining us. So, coming to our choice of topic. In fact, when I asked Dr. Vijay Lakshmi to speak something for this set of events, she was very clear and very sure of what she wanted to speak about. That always gives me a good feeling. I know the person wants to speak about this, and that is the best way. She has lots of experience. She is professor and HOD in Maratha Mandal. She is a PhD guide. It's a great amount of research, and she is waiting to tell us all about the histomorphological variations in the oral cysts. So I think we will not wait any longer, and we will just start. With that, I will hand over to you. Please start.
Thank you, ma'am. Thank you very much for your introduction. And it's always a privilege, madam, to be a part of you and being with you and doing some wonderful work along with you. Uh, in fact, a little bit I was hesitant when you asked me, but then I said I got a chance to talk on this topic, which is of my interest. And I thought it would be more useful for postgraduate students. And thank you very much, ma'am, for giving this opportunity. Uh, Good morning for all the participants who are there. And my topic of my today's presentation is histomorphological variations in cysts of the oral cavity. Mostly, I'll be covering odontogenic cysts, followed by some commonly occurring cysts in the oral cavity, rather than touching on to everything. It becomes too vast to cover everything, and mostly I'll stick on to basic histopathological technique which helps us in diagnosing these histological features. Would be covering under the following headings. So before we go in for any kind of uh, histopathological analysis, it's mandatory that we know some thing about clinical features, radiographic features, of course, macroscopic appearance, which is very important as a oral pathologist. Then I'll deal with topic proper, that is pathognomic features of histopathology of each cyst along with its variation. As you all know, oral cavity is a unique environment, peculiar in its nature, and it is one of the most dynamic organ in the body. And it is made up of various structures, and it is targeted with wide variety of lesions. The lesions which occur in the oral cavity vary in location, etiology, histiogenesis, as well as its presence with variable clinical manifestations. Similarly, orofacial cyst also has varying clinical features and exhibit different histiogenesis, but the occurrence of orofacial cyst within the oral cavity has certain geographic variations in their prevalence, and that has been documented. But the documentation which has happened in context with the cyst is mainly based on either institutional study or some case reports recorded, but as such there is no data like how we do for oral cancer registry. But of course this particular prevalence of orofacial cyst in India is quite limited because of lack of documentation, even though there are quite number of cysts which are reported in at institutional level and at laboratory levels at various places. This makes us necessary to explore more about uh, histological patterns that occur in the cyst, and if at all we come across how to diagnose them becomes important. It was way back in 1974, Cremer defined cyst as a pathological cavity having fluid, semi-fluid or gaseous content, and which is not created by accumulation of pus. And also, cyst can either be lined by epithelium or not lined by epithelium. If it is lined by epithelium, it is referred to as true cyst. And most often, true cysts are of odontogenic origin. There are few non-odontogenic cysts which are lined by epithelium. And cysts which are not lined by epithelium are referred to as pseudocysts. Most often these cysts are soft tissue cysts occurring in the oral cavity, but there are certain jawbone cysts which are pseudocysts like aneurysmal bone cyst and solitary bone cyst. Various classifications have been given in the literature, but most commonly and aptly followed appears to be one given by Shear. 1945, Robinson divided it into odontogenic tissue, cysts arising from odontogenic tissue and non-odontogenic tissue, whereas WHO divided it into only two categories as developmental and inflammatory, and then in developmental, they categorized odontogenic and non-odontogenic, and they categorized inflammatory cyst as a separate entity. Gorlin in 1964 categorized it into four different, and in odontogenic category, he put both inflammatory and non-inflammatory cysts together as well. Whereas Shear categorized this particular lesion in three different categories as cyst of jaws, cyst associated with maxillary antrum, and soft tissue cyst occurring in head and neck region, and then further divided into developmental, inflammatory, and non-epithelial lined and non-epithelial lined. As I spoke about incidence or the prevalence of orofacial cyst in various countries, and this is what the literature I found when I was doing a search. Of course, I could see some good number of cases studied in various countries. When I look into India, I found only one study where they had done prevalence only on South Indian population. Looking at the population, what India is having, the percentage of occurrence which we see here, that means the documentation is either very less or it needs to be enhanced, or we need to have a central registry where we can document all these cases. When you look at entire population, we can just see that most common cyst which occurs in the oral cavity is radicular cyst. Of course, radicular cyst is more common because it is known to occur due to a complication of dentigerous cyst or the sequel of dental caries or the sequel of dental caries. And dental caries is the most common oral disease which we come across along with chronic periodontitis or gingivitis. After that is your dentigerous cyst, because dentigerous cyst is more common because it's mostly associated with impacted teeth, and most common impacted teeth is seen with third molar, which lacks eruption. Either there will be partial or incomplete eruption of the partial or complete impacted molars are seen. Followed by that, we have some cases reported with OKC and other cysts. But if you look at the scenario, there's a very few cases which are associated with calcifying epithelial odontogenic cyst, or in some places GOC is not seen only. At some places paradental cysts are not reported. Especially OKC are not reported in these countries like Brazil, Chile, Mexico, and Iran, suggesting that there is certain geographical variation existing among these orofacial cysts. Now, coming to brief about clinical features, the quite variation is seen in age, but most commonly it occurs in the mid 20s or 30s. Most of the cysts, especially few of the cysts, might even show bimodal occurrence, like we see in OKC and COC, which can occur at the age of 20 to 30 and at the age of 50 to 60. Most of the odontogenic cysts or non-odontogenic cysts show male preponderance, except for two cysts, that is aneurysmal bone cyst and nasoalveolar cyst, which is commonly seen in females. The clinical signs and symptoms of all these cysts generally depends on the extent of the lesion, location, and dimension of the lesion. But most often when we are talking about small cysts, they are diagnosed on routine clinical examination or radiological examination. The reason behind that is they're often asymptomatic, except for inflammatory cysts. Even inflammatory cysts are asymptomatic. The chief complaint of the patient would be asymptomatic swelling which occurs in the jawbone area. Apart from that, he might even complain pain or swelling if cyst becomes infected. A patient sometimes notices a lump in the sulcus, bony hard lump in the sulcus. If there is a edentulous patient, he may take treatment because of displacement of denture. At times, we may even come across discoloration or losing of the teeth, but it is a very rare phenomena to happen where the tooth is loose in case of cyst. If the lesion becomes very large, it might show involvement of neurovascular bundle, especially when we are talking about cysts occurring in the mandibular posterior area. And patient might present with paresthesia, anesthesia. Most of the cysts are slow growing, and if they tend to increase in size, there will be expansion of either expansion of labial and buccal aspect of the jawbone. And when we see only expansion of labial and buccal aspect of the jawbones, it indicates odontogenic origin, mainly odontogenic cyst. If expansion is taking place on either ways, both buccal and lingual, then it suggests to be a lesion which is indicative other than odontogenic, especially when we are talking about odontogenic tumors like odontogenic myxomas. As the cysts tend to increase in size, it might increase in such a way that the outer shells of the bone becomes fragile and fragmented, and then when you do a palpation in that area, it just gives the eggshell crackling. But occurrence of this is a rare phenomena. Apart from that, when you are looking in for clinical signs and symptoms, it also will be a very important aspect that we analyze which site we are looking in for this particular lesion. If you're looking in for dentature cysts, they are commonly seen in association with impacted teeth, especially impacted molars and canines. If you're looking for lateral periodontal cysts, they are generally seen between the two roots. Odontogenic keratocysts are more common in the lower third molar extending into the ramus. Whenever we are looking in for a missing tooth and there is a lesion, we need to be suspicious about presence of odontogenic keratocyst. Most often when we look for these odontogenic cysts, the tooth associated with odontogenic cyst or cysts of developmental origin are vital, whereas when we are looking in for cyst of radical periapical cyst, the tooth associated is always non-vital. Either the tooth is having carious lesion or it has got trauma which has infected the pulp and reached the periapical area. Nevertheless, clinical features will give only a broad classification for all these cysts which I have mentioned, but confirmation of this is slightly little more possible with radiographic examination. Classically, when we look for radiographic evaluation of any of these central lesions or the jaw lesions of the cyst, they appear as a well-defined round or oval areas of radiolucency circumscribed by a sharp radioopaque margin. This radioopaque margin around the radiolucent area determines the slow growing nature of the lesion. The cyst can either present as unilocular or multilocular phenomena, but some cysts like calcifying epithelial odontogenic cyst shows presence of radioopacity within the radiolucency. If cyst appears to be aggressive, then we can see some places a scalloping of the border, root resorption or displacement of teeth. Just to show some diagrammatic representation or radiographic representation of cyst, it's a unilocular cyst associated with non-vital tooth, that is radicular cyst. Lateral periodontal cyst between the two teeth, which appears as a unilocular component, and you can see a impacted third molar which is inverted and a neck of the radiolucency attached to the neck of the teeth, determining it to be dentigerous cyst. This is a CBCT image showing unilocular radiolucency with a well demarcated sclerotic border, with showing only expansion in the buccal area. Multilocular radiolucency in the posterior region of the mandible associated with impacted teeth might be OKC or ameloblastoma. We are not sure, which requires further analysis. And aggressive lesion showing multilocular variation at the anterior region of the mandible, extending from the from premolar to molar area, showing some amount of root resorption and displacement of tooth, which accounts for aggressive nature of the cyst. But nevertheless, it's not always radiograph and clinical examination. There is cyst which is filled with cystic fluid, and aspiration of that fluid is also of valuable acts as a valuable diagnostic aid in zero downing or diagnosis. Whenever cystic aspirate is withdrawn, if we find a straw-colored fluid or a clear straw-colored fluid, it generally indicates a cyst of developmental origin. If it is inflammatory in nature, it becomes slightly yellowish in color. When we withdraw the fluid and then visualize at the daylight and see some shimmering crystals indicative of presence of cholesterol, and that definitely indicates that cyst is infected. Whereas in odontogenic keratosis, we generally find white cheesy material. And when we are aspirating, if we aspirate air or blood, air indicates that either we have entered, if it is in the maxillary area, it indicates that either we have entered into the maxillary sinus, or it might be suggestive of solitary bone cyst. If we withdraw blood, it gives an indication that either we are dealing with aneurysmal bone cyst. When we withdraw the aspirant, it's not only the color of the aspirant which is helpful in identifying which kind of a cyst it is, but it also the protein content of this aspirant also will help us in understanding the uh, type of cyst. If the soluble protein level is less than 4 gram per 100 ml, it generally indicates of odontogenic keratocyst. Whereas if there is increase in soluble protein of more than 4 milligram per 100 ml, it generally indicates developmental cyst of other category and inflammatory cyst. Now, why do we get is because in OKC, the epithelium is quite well organized, and it shows less spongiosis, whereas in other cysts, the epithelial channels are so free that it allows for the connective tissue component to enter into the cystic cavity. Other than that, when we do a smear of the slide, especially in case of OKC, in a proteinaceous background, we can see epithelial cells or squames of epithelial cells, which generally gives an indication that we are looking in for OKC in this particular aspirant. In case of radicular cyst, we generally see presence of cholesterol crystals. When we put the drop of the aspirant on the slide and visualize under the microscope directly, we can usually see a rectangular shaped crystal with notched corner, which is characteristic of presence of cholesterol. And this indicates that either we are dealing with inflammatory cyst or cyst which is infected. Coming to pathogenesis of cyst, a wide variety of odontogenic cysts and tumors may arise from diverse cellular elements of odontogenic apparatus. The cyst may develop de novo or from stimulation of epithelial remnants of odontogenic infections. Anyway, I'll not be going in detail about these pathogenesis of cyst. I'll just put few of the related pathogenesis which can occur. Most of the cyst, odontogenic cyst occurring in the oral cavity or not, arise through a res of dental lamina or res of molasses. There are few which might occur as in case of dentigerous cyst, where there is a fluid accumulation between reduced enamel epithelium and the enamel surface. Similarly, we have some non-odontogenic cysts, especially the fissural cysts, which occur as a result of entrapment of epithelium when the embryonic fusioning of the processes are taking place, and the entrapped epithelium within the process will result in formation of cyst. Whereas there are various other cysts, fissural cysts, which have now been not categorized under fissural cyst, and they say they are cysts of odontogenic in origin. Aneurysmal bone cyst and solitary bone cyst, which is referred to as pseudocysts, have a pathogenesis related to trauma or history of trauma. Whenever we are encountering any cyst, we come across certain structures which are associated with these cysts. They include Rushton bodies, Russell bodies, cholesterol clefts, ghost cells, and of course calcifications, especially dystrophic calcification. Now, before we get into the histology proper of each cyst, let us know little about these bodies. Russian bodies was first identified by Dewey in 1918. They appear as a linear eosinophilic structure which can take up various shapes like hairpin shaped, elliptical shape, oval shape. They might be lamellated, okay, which are seen in the epithelial lining of inflammatory cyst, most oftenly seen in the epithelial lining of inflammatory cyst, especially in radicular cyst. The percentage of occurrence of this particular body in a radicular cyst is about 10%. Out of 100, 10 cases you will come across with this particular body in a radicular cyst. But of course, you can see these particular bodies in any of the other odontogenic cysts if they get infected or inflamed. These bodies measure approximately about 0.1 millimeter and they are refractile in nature, and they are brittle and tend to fracture very easily. There are various theories which have been put forth by various authors, and it was Rushton who first suggested that it is a keratinized secondary enamel cuticle. Later, Gottlieb did a histochemical staining for cystine, and he suggested that this particular body is suggestive of epithelial origin and probably a form of keratin. But many histochemical studies which were done subsequently had no evidence to prove that it is a substance which is a keratin and epithelial origin. But they said that it could be a secretory product of odontogenic epithelial cells, same as that of secondary enamel cuticle. But later, some of them believed it to be hematogenous origin, which is derived from thrombi in venules of the connective tissue that has become varicose and strangulated by epithelial cuffs which encircle them. And that particular phenomena was supported by certain histochemical stains for hemoglobin, and it was Shear who did a staining for those bodies with Pickworth benzidine and found positivity, and he was of the opinion that it is hematogenous origin. But later the question arises is, these bodies are commonly seen in epithelium and very rarely seen in the connective tissue. If it is seen only in the epithelium, epithelium is devoid of blood supply and they were not able to answer the hematogenous origin. But nevertheless, when they did ultrastructural studies, they found a close relationship of Rushton bodies with red cells or blood vessels, and they suggested that it has a more hematogenous origin than epithelial origin. Later, it was confirmed that it is a degenerating degenerating RBCs which are encountered in the cystic lining, and that was confirmed by doing microradiographic or X-ray microanalysis. In X-ray microanalysis, they found presence of macrophages, erythrocytes, and degenerating epithelial cells in the cyst epithelium. And these degenerated cells were undergoing degree of homogenization. And depending upon that degree of homogenization, that is the presence of granularity and absence of granularity, they divided these hyaline bodies into two types. That is type 1 hyaline body with no central granular component that occurs due to homogenization of these degenerated cells, whereas type 2 was associated with granular component. But still, the origin remains unclear or obscure about Rushton bodies. But definitely, when you're doing grossing of this particular component in a cystic wall, you generally find a small, smooth, white dome-shaped swelling on the surface of the epithelium, which will be protruding onto the cystic cavity, which gives an indication macroscopically that we might look into Rushton body when the slide is prepared. Schematic representation of origin of Rushton bodies. Now coming to Russell bodies, also referred as Mott cells, which was first recognized by William Russell in 1890. They appear in the HND stain section as a eosinophilic round mass with eccentrically placed nucleus. These are nothing but the plasma cells which have immunoglobulins within them. This is a higher magnification of the same, where you can see a good amount of eosinophilic material with peripherally placed nucleus. Again, these represent aggregates of immunoglobulins that occur due to the hyperproduction of normal secretory protein within the plasma cells. They occur due to dilated cisternae of endoplasmic reticulum that contain large amount of condensed immunoglobulin. When they stained it for kappa and lambda chain protein, kappa and lambda chains, they were positive, and it indicated that these Russell bodies which occur in the connective tissue wall of the cyst are non-neoplastic in nature. they are prompted by type 1 inflammatory cytokines. Now, coming to cholesterol clefts, most often these cholesterol clefts are seen in inflammatory cysts, especially in radicular cysts. The incidence of it ranges from 28 to 45% in radicular cysts, but it can occur in any odontogenic cyst which is infected, secondarily infected. They appear in H&E stain section as a clear cleft-like spaces dispersed in the connective tissue stroma, fibrous connective tissue stroma. In between these clefts, you can sometimes see presence of dystrophic calcification, and these clefts can even evoke foreign body reactions by formation of giant cells, foreign body giant cells, multinucleated giant cells. And why do you get this clear space? You get this clear space because when you do a processing of the tissue, the cholesterol which within the cleft gets dissolved by alcohol, and under microscope we see them as a clear cleft. And they have found correlation of this particular presence of cholesterol clefts with presence of hemosiderin and macrophages, and they say these are responsible for formation of lipid laden clefts. There is other suggested theory that they are degenerated or disintegrated lymphocytes, plasmacytes, and macrophages which take part in inflammatory process, and then they release in cholesterol from their walls. It's not necessary always you find cholesterol clefts within the connective tissue wall. At times they might migrate into the cystic lumen also. Whenever they are present in the connective tissue wall, they tend to evoke foreign body reaction. Now, ghost cells, these are pathognomic feature of calcifying epithelial odontogenic cyst, and they are specifically present in the epithelial cells. But sometimes you might see subepithelially also presence of these ghost cells in the connective tissue. Again, when they are present in the connective tissue, they have a tendency to evoke foreign body reaction. Excuse me. When you look at H&E stain section, you generally see them as a large eosinophilic balloon round to ovoid cells with central hollow or with a pycnotic nucleus, depending upon the stage of degeneration. You see these cells, and these cells are accumulated or piled in such a way that it appears as a mass of eosinophilic component which is present, and you lack to see any intracellular junction. They also appear as elongated elliptoid appearing cells within the lining of the epithelium. Apart from CUOC, you also see these ghost cells in advanced cell stage of early embryogenesis. You see in ameloblastic fibroodontoma, ameloblastic fibroma, etc. It represents origin. It represents abnormal keratin, have affinity for calcification. Hing et al. Observed that little or no cytokeratin expression present in these ghost cells, but finally they said that it could be a product of coagulative necrosis of odontogenic epithelium, which can occur due to ischemic changes in the odontogenic epithelium. When ghost cells were stained to just rule out it's not a connective tissue origin and it's an epithelial origin, the Van Giesen stain showed distinction between ghost cells and the dentinoid which is laid down below the epithelium, suggesting that it is not a connective tissue origin. Of course, when rhodamine B reaction was carried out for these ghost cells, they appeared similar to that of keratin on fluorescent imaging. Now, coming to calcification, which is most commonly seen in most of the cysts of odontogenic origin, they appear as a small flakes of irregular hematoxyphilic component within the cystic wall, or at times they might be associated with these Russian bodies or the ghost cells where we can see a presence of these calcifications. These are nothing but a direct deposition of calcium salts within the tissue occurring at the areas of necrosis or degeneration, hence suggested to be tissue of degenerative origin. Histologically, when you're looking for these hematoxyphilic bodies, you generally see some amount of retraction artifact around the hematoxyphilic component, as you're seeing here. And this calcium deposits are generally rich in calcium phosphates. or inorganic phosphates. Whenever we are looking into the orofacial cyst, it's always necessary as a pathologist we give due importance for the macroscopic appearance of the lesion when it comes to the laboratory. Of course, when we talk about orofacial cyst, not always we get a cyst intact like this, how I have put here. Generally, if extraction of a tooth is done associated with a periapical area, cyst associated with a periapical area, then it generally comes in toto. But other odontogenic cysts or developmental cysts, which I'm talking, they generally don't come in toto. They might get fragmented. And when we get a cyst in toto, you can see the cyst shrunken because the cystic component within the cyst is already lost. And there will be a small hole, which you can see here, which indicates that there is a cystic cavity. And cut open of the cyst, this particular cyst will give you a cystic cavity and a cystic lining around the cavity. It's always necessary when you have this cystic lining and the cystic cavity, palpate it and check for presence of any nodularity or any discoloration or any projections within the cystic wall, because this gives us an indication how a histopathology of the cyst would look into. Either we might expect some hyperplastic epithelium, or we might expect some proliferation of tumorous component, or we can expect some kind of a bodies, as I spoke in case of Rushton bodies. Most often, we don't receive classic histogrossing specimen or macroscopic specimen in the laboratory, but nevertheless, sometimes we do receive a cyst which is, covering only the neck of the tooth, which indicates it's a dentigerous cyst, or a multilocularity, as in aneurysmal bosses, that note down the reddish discoloration of the specimen which was freshly removed. Probably when you fix it in the abdomen, it appears more blackish in color. Lateral periodontal cyst, it's a classic one on extraction. You can see a cyst on the lateral aspect of the. In conclusion, cysts of the oral regions occur commonly owing to mouth's complex embryonic origin and frequency of inflammation. Knowing classification of cyst is important to understand the terminology. Histopathological diagnosis is very important for the management of this particular orofacial cyst, and it acts as a cornerstone for treatment. Thank you.